My name is Michael Manz. I have the privilege to chair the Department of Gastroenterology, Hepatology and Endocrinology for the last 25 years. We are here based in Hanover Medical School, which is one of the largest medical schools in the country. Hanover is the capital of Lower Saxony, one of the 16 states of Germany. We are located in the north of Germany. The medical school is hosting 1,500 beds, and we take care of 55,000 inpatients per year and 350,000 outpatients. As clinical service, our department is having a major focus on liver diseases, scientific-wise inflammatory liver diseases, with particular focus on viral hepatitis and autoimmune liver diseases. The whole medical school has research interests and focuses in infection and immunity. Here, our department is very active. We have an infectious disease ward, 20 beds we share together with immunology and rheumatology. The infectious disease center of our medical school, where we are a major part of, is part of the German Center of Infection Research. Here I chair the viral hepatitis group. We have further emphasis on GI infections. Furthermore, the medical school have a strong emphasis on organ transplantation and regenerative medicine. Hanover Medical School is the largest transplant center in the country. We are running the longest running and the oldest liver transplant program in the country. It's one of the 3-4 oldest programs in the world, founded by the late Professor Pischelmeier. And we have also a research focus. I personally chair a project on organ transplantation. We are embedded in the Center of Excellence of Regenerative Medicine, chaired by our cardiac surgeon, and we have various groups in the department concentrating on cellular therapies, including hepatocyte transplantation, iPS technology, animal models, to develop future methods for liver and organ transplantation. Clinically, our department, apart from hepatology, is doing GI gastroenterology with a strong emphasis on inflammatory bowel disease and immune-mediated diseases. We are serving central endoscopy units for the whole medical school. We have a central ultrasound unit, and we have a long-lasting experience on invasive procedures, on all kinds of interventional endoscopy and interventional ultrasound technology. Together with transplant surgery and nephrology, we are running a joint organ transplant unit for abdominal transplantations. We are running various outpatient services, including clinical trial units, viral hepatitis, inflammatory bowel disease, and the transplant outpatient unit together with surgery and nephrology. The third emphasis and scientific focus of the medical school is dealing with bioimplants and biotechnology. Here is the only focus where our department is not strongly involved yet. We are really experienced in doing clinical trials. We took part in all the major trials on viral hepatitis, including B and C in the past. With our network of competence, HepNet, we are having the HepNet study house, where we are doing national and international trials, for example, on acute viral hepatitis, also on chronic hepatitis delta. The network of competence was founded in 2002. It was originally funded by the German Ministry of Research, and in 2006 we founded the German Liver Foundation, which continuously runs the network of competence, including HepNet Study House. Our strongest scientific collaborator is the Helmholtz Institute for Infection Research, based in Braunschweig, and together with the Twin Core Institute, we are doing a lot of translational work on infectious diseases and regenerative medicine and immune-mediated diseases. Number 2 indication of liver transplantation following hepatitis C is primary sclerosing cholangitis, and therefore, with our interest in inflammatory autoimmune liver diseases, inflammatory bowel diseases, and the transplant program, we have the possibility to recruit as a tertiary referral centers many patients with primary sclerosing cholangitis. We are taking part in all the major trials. We are taking care of more than 600 of such patients which may develop a life-threatening cause, as we will discuss in the time to come. So it's my real great pleasure to introduce to you Privatdozent Dr. Torsten Voigtländer. He is a clinician scientist, an experienced endoscopist. He's a clinician scientist in our unit, and he has a special interest in endoscopy and including primary sclerosing cholangitis. And it's my pleasure that he will introduce us a very specific case that we will discuss for you. Dr. Voigtländer.
Thank you, Professor Manns, for the introduction. I'm going to present a case report from Professor Manns' unit, and let's go. It's about a 22-year-old male patient who presented in August 2012 at our institution. He was referred to our hospital with pain with jaundice, pruritus, and abdominal discomfort. In a local hospital, the diagnosis of PSC was already made in April 2012. His BMI was a normal range, and there was no significant weight loss or fever, and his medical history was without pathological findings. So the clinical examination showed that the patient was jaundiced and he had abdominal scratch marks. The further clinical examination was without pathological findings. His vital parameters were normal range, and already a therapy with urso and antihistamines was initiated, which led to an improvement of pruritus. The laboratory parameters at this point were elevated, especially the transaminases and the cholestatic parameters. Bilirubin was nearly tenfold upper the limit of normal. CA99 was also significantly elevated. So there was already an MRCP done in June 2012, which showed typical intrahepatic PSC findings and a stricture in the common bile duct. So we performed an ERC at our institution, and we saw the typical intrahepatic PSC findings and the stricture of the extrahepatic common bile duct. We did sample acquisition with forceps biopsies and brush cytology, and finally placed a stent to assure an adequate biliary drainage. So the pathological examination showed that the brush cytology only showed small amounts of bile duct cells. There were only signs of inflammation, but no tumor. The same was true for the forceps biopsies. In the abdominal ultrasound, we saw signs of sclerosing cholangitis with stenosis of the extrahepatic bile duct and large lymph nodes around the common bile duct. So, as further diagnostics, we performed a colonoscopy and a gastroscopy. We saw a mild left-sided colitis. We initiated its therapy with 5-ASA due to this ulcerative colitis. In the gastroscopy, there were no signs of esophageal varices. At this time point, all laboratory parameters were nearly at normal range, especially bilirubin and CA99. So to summarize, at this point, at August 2012, we have this PSC patient with a dominant stricture, no histological finding of a tumor, CA99 was in normal range, we had large lymph nodes, and a stent was placed. Furthermore, he had a mild ulcerative colitis. So we saw the patient again in September 2012. He was clinically well, but we repeated the ERC, took specimens, removed the stent, and we did not find a tumor. All samples were negative. At this time point, the laboratory parameters were completely normal. Then, in October 2012, we saw the patient again. He complained about fever and jaundice, and the ultrasound showed dilated intrahepatic bile ducts and the stenosis of the extrahepatic bile duct. So we again performed an ERC, performed the dilatation and stent placement. At this time point, the laboratory values were again elevated, especially the transaminases, the cholestatic parameters, and CA99 was not determined. So the next follow-up was in January 2013. The patient was clinically well. He had no signs of cholangitis, and we again performed endoscopy without signs of a tumor. At this time point, the laboratory values were also at normal range. They were all normalized. So we performed an abdominal ultrasound, which showed a hypoechogenic mass close to the common bile duct. It was approximately 3 centimeters in diameter. So the next step was an endoscopic ultrasound. We performed this method and saw a mass and big lymph nodes infiltrating and compressing the common bile duct. We performed a fine needle aspiration, but we did not obtain enough material for pathological analysis. So at this time point, we have this young patient with a suspected cholangiocarcinoma and performed an explorative laparotomy. And we found an irresectable cholangiocarcinoma. The common bile duct was already surrounded by the tumor, and large arteries were infiltrated by this tumor. Lymph node metastases were also present at this point. Professor Manns, can you please comment on this diagnostic dilemma of the CCA diagnosis in patient with PSC?
Yes, the clinical course of this patient really is disappointing. It's a typical young male patient with primary sclerosing cholangitis. He has associated ulcerative colitis. And from the beginning, from the diagnosis in April 2012, there has been a suspicion for cholangiocellular carcinoma. We applied all technology available. We did MRCP, but also invasive ERCP. We did brush cytology of the bile duct and the bile. We did forceps biopsy of the strictures, and we also applied ultrasound technology, endoscopic ultrasound, whatever was available. We always suspected the development of cholangiocellular carcinoma, in particular when at time of diagnosis, the tumor marker CA19-9 was high, was above 700, which is really indicative. We know that it's rising when we have cholestasis or inflammation. But can you give any comment, Dr. Voigtländer, how it come that it returned to normal from such an extent?
In my opinion, it's like that it still, or it again reflects that CA19-9 is not a good tumor marker. It just means there are a lot of benign states or biliary diseases which lead to an increase of CA19-9 and also tumor diseases. But as you said, it's the weakness of CA19-9 because maybe he had a tumor, I don't know, at this time point, but after the cholestasis was resolved, it normalized. So CA19-9 is just because of this fact not a good marker.
And this was CA19-9 in blood, in serum.
Yes.
Did we test for CA19-9 in bile?
We do not do that regularly, and in this specific case, we also did not perform this analysis.
Having that said, so the serological tumor markers, the classical ones, are disappointing. All the other diagnostic procedures are invasive, doing ERCP, doing papillotomy, doing forceps biopsy, brush cytology has a low sensitivity of 40 to 60%. And despite doing all this with all the potential complications like pancreatitis and inducing cholangitis, we do not have reliable biomarkers. And we need biomarkers in order to discover dysplasia development before manifested ovarian cholangiocarcinoma develops, because we want to make the indication for transplantation early before cancer development. So therefore, I think we need to look for, and at our institution we invested a lot in this area, and Professor Lankish for many years collaborated with Mosaic's company, a biotech company which is specialized on the analysis of proteomics and proteomic profiles. They collaborated with nephrology and hematology and have produced successful results. They developed methodology to analyze proteomics in urine for early diagnosis of diabetic nephropathy, and in particular they have been successful identifying a proteomic profile that is indicating the development of graft versus host disease after stem cell and allogeneic bone marrow transplantation. And they provided literature with a prospective trial that once they discover the development of proteomics profile in urine indicative of graft versus host disease, they could show that preemptive treatment of steroids in a prospective controlled trial could prevent development of graft versus host disease. And this encouraged our institution to look in proteomic profiles, first in bile and later in urine, as a new biomarker to discover the risk and development of cholangiocellular carcinoma. And Dr. Voigtländer is also very active in this field, and he's continuing the work started over years by Professor Lankisch. And maybe you can explain this technology to us, and please, we would like to know more about this.
Yeah, as you already said, the proteomic analysis is an approach which analyzes complex protein patterns in different body fluids like bile and urine. And as our focus is or are biliary diseases, we wanted to analyze if by analysis of complex protein patterns we can diagnose certain diseases like cholangiocarcinoma in patients with PSC.
This is the typical picture. If you would be kind enough and explain, first of all, what the patterns for PSC with and out cholangiocarcinoma are and look like, and then maybe you tell us what you did find in our patient.
As shown in this picture, you see different proteomic profiles for different disease stages. Here on the left panel, this is the proteomic profile for patients with PSC. This one is for patients with cholangiocarcinoma, and this one for patients with cholangiocarcinoma on top of primary sclerosing cholangitis. And in general, the proteomic approach, it's in our institution or in our version, it's like a mass spectrometry coupled to capillary electrophoresis, which means that we can identify proteins, and the peak of the proteins says something about the amount which is in the different body fluids, and so you can modulate or you can generate specific or disease-specific patterns which may help to diagnose different disease states.
Are these single peptides, or is it a pattern of peptides?
It's a whole pattern, and sometimes it's not only whole proteins, it's also little fragments of proteins, and the specific pattern says something about the disease or is necessary to diagnose the disease.
Are these unknown proteins or fragments of unknown proteins, or are the proteins known?
In general, most of them are known. Some fragments are not known, but they are little fragments from hemoglobin or other known proteins, and it's really the pattern or the composition of the body fluid which is indicative for the disease state.
Could you explain what you found in the bile of our patient?
In our patient, unfortunately...
When was it taken? When this bile, was it taken at the time of diagnosis?
Yeah, in this case, the bile was taken on time of diagnosis. It was in January. Yeah. And unfortunately, we have to say at this time point, the diagnosis could not be made by this test because it was negative or below the cutoff for cholangiocarcinoma. But on the other hand, we also performed the analysis in urine. And as you can see here, again, the different specific patterns for the disease states of PSC, cholangiocarcinoma and cholangiocarcinoma on top of PSC, they are differing, and our patient scored positive for cholangiocarcinoma.
It's on the lower panel. Yeah?
It's the lower panel, yes.
Lower panel. And Dr. Metzger, Dr. Lankisch, they published on this recently, and so this is for me difficult to understand. Are these completely different proteins that you analyze and discover in bile and in urine? Is it not just a spillover?
As you indicate, the protein patterns are completely different because urine is then excreted and the proteins are modulated, so it's difficult, or it's maybe an epiphenomenon of the tumor. And however, nevertheless, this protein pattern seems to be indicative for different disease states, as you also indicated, or what you said about different other states of renal dysfunction, you can diagnose diseases like this.
So in summary here, we would say that in this particular patient, when the bile was analyzed at the time of diagnosis of cholangiocarcinoma, there was not a typical proteomic profile for cholangiocarcinoma, but the typical pattern was found in urine. So this is more or less gives also some questions in addition to answers. So what else can you explain us about the technology?
Yeah, as you said, this was for us also a bit disappointing, but we analyzed it further and we found that when you combine both analysis, which means the bile and the urine analysis in a logistic regression model, then you can, or our patient scored then also positive for cholangiocarcinoma. somehow we have the feeling that the urine analysis is very good, also because it's not invasive in comparison to the bile analysis. Yeah? And in this logistic regression function, the combination of both tests, we could show that the patient scored positive for cholangiocarcinoma. But you're right, the bile for this patient was disappointing, which does not mean that it's true for every patient, because what is necessary is that we have a lot of samples to adjust and refine this pattern, and then it will become better and better, especially what is
work in progress.
Yes. And to say the last sentence about our patient, unfortunately, some month after this diagnosis, or immediately, he received palliative chemotherapy and died several months later.
So it was a rapid progressive course. If we state that in April 2012, when the diagnosis of PSC was made, there was no discovery and no indication of cholangiocarcinoma, and an irresectable and rapid progressive course of the tumor was found in January 2013. So this is really a dilemma, and we need to develop biomarkers in order to diagnose early enough. But then again, the question is whether there would never have been a chance for this patient to receive a liver transplant, because in the MELD score system, he was far below the threshold of 25, 30 when he has a chance of getting a transplant. And for standard exceptions, he did not have recurrent cholangitis, he did not have weight loss, so he didn't have a chance to receive an organ via the standard exception criteria.
Maybe we can discuss some critical points from this case right now, because I wanted to ask you that this specific case, the patient developed very early this cholangiocarcinoma within the first year after the diagnosis of PSC was made. So maybe you can again specifically comment on this patient and the tumor risk in general in patients with PSC.
Yeah, I think first of all, PSC is not only a liver disease. We have PSC, we have ulcerative colitis, we have a lot of extrahepatic manifestations, and thanks to the pioneering work of many centers, in particular the centers in Sweden, we learned a lot about the increased risk. 161 times increased risk to develop cholangiocarcinoma. But we have to look for other tumors. We know that pancreatic cancer is increased, which makes sense because bile ducts and pancreatic ducts have a similar origin. And also the risk for colonic cancer is increased, 10 times increased. And on the other hand, we know that the cancer risk for colonic cancer in ulcerative colitis is increasing once the disease has a longer time course than 10 years. But we have to say that if a patient with ulcerative colitis has primary sclerosing cholangitis, his risk for cholangiocarcinoma is at least doubled. So these patients must have surveillance for their tumor development. But what this patient teaches us, surveillance only makes sense if we have a chance to diagnose tumors in a curable stage, which we missed because this patient under surveillance developed irresectable bile duct cancer. So I think this is a real dilemma.
Maybe you can also comment on the fact that he developed the cholangiocarcinoma that early. Is it typical, or?
Yeah. Overall, we must say that we have PSC is highly prevalent in the Nordic countries. It's number one indication for liver transplantation in Scandinavia. Overall, the risk is depicted here is between 8 and 13%. Roughly 10% develop cholangiocarcinoma, and it's also common sense that the majority of these patients develop within the first year after primary sclerosing cholangitis, which was also the case in our patient. So what is really disappointing that despite the fact that we were aware of the risk of this patient and the images we saw with the strictures, he obviously developed cholangiocarcinoma under our surveillance and under our eyesight.
This leads perfectly to my next question, because I wanted to know how is a good strategy to surveillance or for surveillance of such patients? How can we improve?
Yeah, there is some indication in the literature. Also, the European Association for the Study of the Liver, EASL, has published recently guidelines on cholestatic liver disease, including primary sclerosing cholangitis. This is well documented. Overall, I think we see these patients every 6 or 12 months, and once a year they should receive an MRCP, and certainly they should, if there's any indication of dominant strictures, recurrent bacterial cholangitis, they need to have invasive procedures like ERCP in order to do prostatology, in order to do biopsy, intraductal ultrasound. But it would be very important to evaluate and develop these surveillance strategies in a prospective manner. And there is the international PSC study group, which is doing excellent work, starting with genetics, clinical trials. And I think the international community not only has to develop new therapeutic approaches with drugs and medication, they also need to validate the surveillance procedures, which is very important for the patient. And the goal must be to diagnose pre-malignant diseases that can be cured.
Yeah. You somehow also said a bit about the screening method. So we have to summarize that until now there's no clear benefit from surveillance strategies in patients with PSC. Just wanted to say this at the end. But I also have another question, and you also said something in this direction before, because I wanted to talk about liver transplantation in this patient. So do you think it would have been a good candidate for transplantation?
To be honest, if he would have been transplanted at the time of diagnosis, I'm sure his life would have been saved. But the method of allocation of organs doesn't allow him to get along. So I think patients with primary sclerosing cholangitis, in our way of organ allocation, are underprivileged. Since some time we have these standard exceptions, but this didn't help him because he didn't have weight loss, he didn't have recurrent cholangitis. So this patient here, it really shows that these patients are underprivileged in the allocation system for organ transplantation, liver transplantation, as we use it of today.
Okay. Maybe at the end of the discussion I wanted to ask you, maybe you can point out what are the lessons to be learned from this specific case? What can we do better?
I think this case clearly demonstrates that primary sclerosing cholangitis is the big black box of hepatology. I think now that hepatitis C is solved, we see a lot of focus now on cholestatic liver diseases, primary biliary cirrhosis, and primary sclerosing cholangitis. The motive for the pharmaceutical industry is to develop drugs and for the investors to achieve a return of their investment. But our motive is seeing all these patients all the time. These are young, otherwise healthy individuals who have, for example, ulcerative colitis, so unpleasant symptoms. And in addition, they develop this primary sclerosing cholangitis. Many of them are not aware of this. I think we have to learn more. And I think what is very important, every patient with ulcerative colitis needs to have a thorough investigation, needs to have MRCP regularly. And I think this patient teaches us that the surveillance technology we have in place at the moment is missing biomarkers that help us to identify pre-malignant states that help us to prevent a deleterious cause like in this patient. We couldn't get him a transplant, we couldn't diagnose early enough, and once the cholangiocarcinoma has developed, it ran a very progressive course where even palliative chemotherapy, as we had the impression, didn't help him significantly. So overall, I think PSC is the number one and the only identified risk factor for cholangiocellular carcinoma. It is difficult to diagnose in the PSC patients. Our patient demonstrated that once PSC is diagnosed, the first year, the highest probability is to develop cholangiocarcinoma. Serological tumor markers like CA19-9 are disappointing and not reliable, are misleading. Patients with PSC cholangiocarcinoma sometimes are asymptomatic. Sometimes we diagnose them even only in the stage of irresectable and not curable cholangiocarcinoma, and we urgently need new therapies, but we also need new technology and new international efforts to establish surveillance strategies and biomarkers that help us to diagnose pre-malignant stages at a curable time point in order to save lives for these otherwise healthy patients with a young age. So this is a very impressive case. Unfortunately, we could not save the patient's life, and I think we have to intensify our efforts in an international collaborative fashion. Nevertheless, I hope that you enjoyed the discussion and feel sympathetic towards any efforts to invest in research in this deleterious disease, the black box of hepatology. Thank you very much for your attention.
Thank you for this discussion.